Good evening, everyone. Welcome to the IPNA endorsed Webmaster Series 2020. So today we have entered into the webinar 16 and it is spanning from September 12th to December 23rd. The next few webinars will be on glomerular diseases. And today we have three eminent speakers, Dr. Pankaj, Dr. Gopalakrishnan and Dr. Jubaida. Dr. Pankaj will be moderating the session for the day. And a kind request, we'll be receiving the questions in the question and answer section, and you can drop your questions and we'll be taking up the questions verbally towards the end of the session. So I call upon Dr. Pankaj, who is the moderator of the day. Dr. Pankaj is a professor, Pediatric Nephrology, Department of Pediatrics at All India Institute of Medical Sciences, Delhi. And he has extensive research in vesicoureteric reflex and nephrotic syndrome. And he is a counselor of IPNA from 2020 to 25. And he is also a vice chair of IPNA Best Practices and Standard Committee. He is also awarded as a Fellow of Indian Academy of Pediatrics in the year 2015. He has served as a president for ISPN between the year 2014 to 15, and he has also served as a secretary for Indian Society of Pediatric Nephrology between 2001 to 2009. A key opinion leader of pediatric renal transplantation by the Transplantation Society in 2009. So over to Dr. Pankaj. He will be moderating the session for the day.
So thank you, Kalaivani, for a very kind introduction. So the first talk is going to be on C3 glomerulopathy, and I'm going to present a brief background of this disease. This is considered to be a rare disorder, with the incidence being 1 to 2 cases per million population. And this is a disease which was previously called as membranoproliferative glomerulonephritis. This was chiefly because of the pattern of injury on the histology that this disease was labeled as MPGN. It was only in last 1 or 1.5 decades that there has been a paradigm shift in the understanding of this disease that has led to improved understanding as to how this disease is caused and what is the pathophysiology and pathogenesis. So we now recognize that this is caused by dysregulation of the alternative complement pathway. And it's because of this dysregulation that the injury results in C3 glomerulopathy. So this is a very simplistic classification which was proposed in 2012, where MPGN was classified as immune complex mediated MPGN, or it was classified as C3 glomerulopathy, and if it has predominant C3 deposition. And if when there was less of C3 deposition or no C3 deposition, predominantly immunoglobulins, then it was classified as immune complex mediated MPGN. And further, C3 glomerulopathy is classified based on electron microscopy and the presence of electron dense deposits into either a dense deposit disease or C3 glomerulonephritis. So the term C3 glomerulopathy was largely adopted in 2013 by the expert consensus. Now, however, while this classification of C3 as a dominant deposition in C3 glomerulopathy was initially supposed to be only C3 deposition, however, people figured it out that only C3 has a very poor sensitivity. So it was decided that it should be actually dominant C3 deposition. So if it is dominant by at least 2 orders of magnitude as compared to other immunoglobulins, then it is labeled as C3 glomerulopathy. And of course, electron microscopy is a very important component in classifying this disease. Despite this classification, there is a lot of overlap between the 3 conditions: the dense deposit disease, C3 glomerulonephritis, and even immune complex membranoproliferative GN. And to the extent that sometimes patients are diagnosed initially as IC-MPGN, they later are classified as dense deposit disease, that I will show you in our cohort of patients as well. And overall, people have realized that the outcome of the 3 conditions is not very different, while it was believed that dense deposit disease is supposed to have the worst prognosis. So in addition, the other challenge that lies with C3 glomerulopathy in diagnosis is that it's overlapped with post-infective glomerulonephritis. And sometimes the presentation of C3 glomerulopathy can be like a post-infective GN. And the only clue to diagnosis, therefore, then would be to find out if there is persistence of C3, low C3, and persistence of proteinuria and active sediment, then you must consider that this could be a C3 glomerulopathy instead of a post-infective GN. And it is likely that the initial biopsy may show some immune complexes. So what is proposed is that the initial trigger may be through the classical complement pathway, which is followed by the alternative pathway, and the alternative pathway then remains dysregulated, evolving into C3G. So as far as the evaluation of C3 glomerulopathy is concerned, one has to examine all the complement pathway proteins, C3, C4, CH50, and it is also proposed that there can be variations in certain genes of which determine the regulatory proteins of the complement pathway, like complement factor H, factor I, MCP, etc. Now, these are more important with atypical hemolytic uremic syndrome. So when I say atypical hemolytic uremic syndrome, this is another disease that is caused by dysregulation of alternative complement pathway. So these two diseases are C3 glomerulopathy, belong to a spectrum of dysregulated alternative complement pathway. And it is actually when there is a dysregulation in the fluid phase, one develops C3 glomerulopathy, and if it is in the cell surface dysregulation, that one develops atypical hemolytic uremic syndrome. In addition, the drivers for C3 glomerulopathy are certain antibodies, and very widely known for years is C3 nephritic factor, which results in persistent activation of C3 convertase. In addition, there are antibodies against factor B and factor H that have been identified. We've been working on this disease for last almost about 6-7 years, and we have tried to establish some of the assays. So we've been doing anti-factor H antibody levels for last almost a decade, and chiefly for the atypical hemolytic uremic syndrome, where almost more than 50% patient would have this presence of anti-FH antibodies. On the other hand, in C3 glomerulopathy, the anti-FH antibodies are seen in just about 5 or 7% patients. And it is also believed that these antibodies are different and may not be pathogenic. We also tried to establish factor B antibodies very recently. About 6 months back, we were able to establish this assay, and we found that about 10%, 7 to 10% of our patients had the positivity for anti-factor B antibodies. C3 nephritic factor is more commonly seen in dense deposit disease as opposed to the others. So these are the set of investigations that have to be done if you suspect a patient to be suffering from C3 glomerulopathy. And unfortunately, a lot of these are not available in our country, and we're trying to establish all these assays at our lab. We were also been following up these patients and of C3 glomerulopathy and MPGN for last almost a decade or so, and we very recently published our experience in pediatric nephrology, 92 patients who had a median follow-up of 4 years or so, and of these 48 had dense deposit disease, and 26 had C3 glomerulonephritis, while 18 patients were classified as IC-MPGN. Now, what we figured out over a follow-up period of time that at least 8 patients were misclassified to have immune complex MPGN because of the deposition of immunoglobulin IgG, and later on these patients were found to have actually dense deposit disease. We treated these patients with mycophenolate mofetil, which is the recommended treatment by the KDIGO as well. But however, the response you could see is quite dismal. Tacrolimus was tried in patients who failed on mycophenolate, and in some of the patients we de novo started tacrolimus, and also some of the patients who presented as rapidly progressive GN, these were treated with IV cyclophosphamide and prednisolone. If you can look at the response to therapy over a period of 12 months' time, just about 20 to 30% patient had some kind of a response. So it is a very poor response to treatment. And when we looked at the 5-year survival, we found that somehow in our cohort of patients, dense deposit disease, they did very poorly as opposed to C3GN and IC-MPGN, while the other cohorts from the US, the Mayo Clinic, they have shown that there may not be much of difference between all the 3 components of MPGN. We also found that RPGN was associated with poor outcome and complete remission was protective. So there is a challenge about therapy of this condition. Optimal therapy is not established. Mycophenolate, we have seen, mycophenolate is not very effective. Plasma exchanges are also, even in cases which are presenting like RPGN, they're not very useful as opposed to what we will see in atypical hemolytic uremic syndrome. One drug, which is eculizumab, which is a C5b inhibitor, So this is a monoclonal antibody, and if you can look at the pathway of complement dysregulation, which is shown here, the C5b blocker, which is very effective in atypical hemolytic uremic syndrome. Unfortunately, even this drug doesn't work very well in MPG and in C3 glomerulopathy. And the reason is that if you can figure out that this is the one that blocks the generation of C5b9, which is the membrane attack complex or the terminal complement activation. So despite that, when we block this by using eculizumab, the activation of C3 and formation of C3 convertase continues, and therefore the C3 breakdown products, the C3D effect, C3BB, they keep getting deposited in the glomerular basement membrane, resulting in persistent proteinuria and progression of disease. So what we need therapies are in the form of complement blockers that can block either C3 or a blocker of a factor B. And fortunately, these two blockers have become available, and there are phase 3 trials which are likely to be beginning. The factor B inhibitor, which has undergone a phase 2 trial, has been shown to be effective and is an oral drug. Very recently, C3 inhibitor has shown promise. The discovery study, which was recently presented as a poster in ASN Week last month, this is called as pegcetacoplan, which is from the Apellis Pharma. It was tried in 5 patients of C3 glomerulopathy, and it was shown to result in very significant reduction in proteinuria, 65% over a period of 48 weeks, with a sustained increase in serum albumin and C3 level. So it is likely that in future we may be having some new therapies that will change the course of disease and change the prognosis of this condition, because in fact, despite all the treatment that is currently available, majority of patients would progress to ESRD and would also, and the other issue is that particularly for dense deposit disease and even C3G, and there's a very high recurrence rate in the allograft. So we will listen to all these issues on C3 glomerulopathy now with Dr. N. Gopalakrishnan. And he is the presenter for the talk. Dr. Gopalakrishnan is the director of the Institute of Nephrology, Madras Medical College. He established the dialysis services at Chengalpattu Medical College and established the maintenance dialysis unit at Madras Medical College. He's an associate editor of Indian Journal of Nephrology and is an institute body member of All India Institute of Medical Sciences. He's a member of ISN SARB and a member of ISN ANIOCKT committee, and has several publications to his name with several chapters and books, and he's also a recipient of several oration awards. So now I invite Dr. Gopalakrishnan to present his talk on C3 glomerulopathy. Dr. Gopalakrishnan, please.
Very good evening. Am I audible?
Yeah, you're audible, sir.
Very good evening. Thanks for the wonderful opportunity to deliver a talk. Particularly my special thanks to Dr. Kalaimani. I know how difficult it is to arrange and organize a series of web lectures. It is not easy, so much of labor and so much of sacrifice of personal time and so on. Thanks to you so much, and congratulations, Dr. Kalaimani, because this should be the spirit of every academician in disseminating the information and knowledge across. Thank you so much. Kudos to you. Thanks very much, the chairperson, for nice introduction. And also you have made my job very, very, very easy. Almost every component of the C3 glomerulopathy you have already mentioned. So I don't know how to design my lecture now. Anyhow, I'll try to kind of give stress and emphasis on the points of interest and areas of uncertainty and the things to ponder over and what is the scope for future research and so on. I'll lay more focus on that. Yeah, this is, as the chairpersons already pointed out, this is a classical disease which is due to the dysregulation of the complement pathway. Is it not a wonder? I never thought that the complement, which is one of the major defenses of our immune system can turn out to be such a notorious villain. When I came to know such a fact that complement can cause a disease during my MD general medicine time, when I learned about paroxysmal nocturnal hemoglobinuria, that is the first disease where we learned that the complement can injure and complement can cause disease. And next only to that is this group of diseases which are broadly known as the C3 glomerulopathy. So to understand further, let us quickly recapitulate our basics. So this is the complement pathway, the classical pathway, the alternate pathway, and the lectin pathway. A word about lectin pathway. Normally we don't talk much about lectin pathway, and now there is a lot of focus and a lot of emphasis on lectin pathway associated diseases as well. Anyhow, that is beyond the realm of today's discussion. I will not touch upon that. What is the basic difference between this classical pathway and alternate pathway, which is older by the way? The phylogenetically, the oldest is alternative pathway, meaning that evolution of a very robust alternative complement pathway is primarily responsible for protecting the humans against microbes for thousands and millions of years. So it has evolved very, very, very old, much earlier than the classical pathway. What is the essential difference between the two? For classical pathway, you need something to activate it. To get activated, the normal state of affairs, it is not in an activated form. Whereas alternative pathway is always in a state of mild activation. Why is it so? It is one of the integral components of the innate immunity. Whenever there is a microbial challenge, for instance, it is ready to attack. So it is in a state of mild activation. This is the essential difference. But how this mild activation is important? Mild adjective is very, very important. If the level of activation is a little more, the exaggerated complement activity can injure our own tissue even without a microbial challenge. How is it not happening in the normal instance? Please look into this picture. As you can see here, there is a beautiful balance of activators, that is promoters of activation of alternate complement pathway versus the inhibitors. Otherwise, we'll call it as regulators. The regulators and the promoters or activators have to maintain a beautiful balance. By any chance, if there is a tilt in this balance, favoring activation, that will result in exaggerated activation of the complement pathway, and that will lead on to all the injuries. That's what is happening here. So let us quickly recapitulate the inhibitors. And this is the pathway. I will not talk about the classical pathway. We are not dealing with that now. So it starts with C3. C3 gets activated, C3A and C3B, and C3B. And you know, this is the C3 convertase of alternate complement pathway, that is C3B, BB. Okay. So the C3B enters into an amplification loop, and there is production of more and more and more of C3 convertase, which results in conversion of C3 to C3B. Okay. Then finally you get C5 convertase, and that acts upon C5, that activates C5, that results in C5A and C5B. And C5B enters into the formation of final membrane attack complex that we all know, C5B to 9. Here, the important things we have to know is that C3A is an anaphylatoxin and C5A is another potential injurious component. Again, it is an anaphylatoxin, meaning that both these are capable of inviting, attracting the cells of inflammation, neutrophils and monocytes and macrophages and so on, that can cause a lot of injury. And again, C5B9, that is a membrane attack complex, there is a terminal component, and that causes a direct injury on the cell, right? So here, the most important inhibitor, how this activation loop is normally kept at a check without going beyond that mild state of activation, is the most important is factor H. It competitively binds with C3B and prevents further proceeding of this pathway, right? It prevents its activation. And similarly, the other ones are the other most important regulators of factor I and DAF, DK, accelerating factor, membrane, cofactor protein, and so on. These are the most important regulators. And finally, CD59. So this is the basics of the complement pathway. And if that results in a kind of a dysregulation, we are in for a disease that is broadly classified, known as C3 glomerulopathy. Let me quickly go with a case vignette. A 12-year-old boy who reports to the hospital with 3 days of edema, oliguria, and facial puffiness. On evaluation, his BP is pretty high, and the lab show 3+ proteinuria and plenty of RBCs, and the RBC cast. Creatinine is elevated 1.3, and urine spot PCR protein creatinine ratio is 3.1. So the working diagnosis, so it is an acute nephrotic syndrome. Nephritic because the RBC cast is there. If there is RBC cast, the importance of RBC cast is there. If there is an RBC cast, it's 100% there is a glomerular injury. Why is it so? RBC cast is equal to RBC plus hyaline cast. Hyaline cast is formed in the thick ascending Henle's loop. It's nothing but a conglomerate or the mold or the tubular mold of Tam-Hartsford protein. So the RBC has to come proximal to that. So it is, what is proximal to that? It is glomerular. So whenever you demonstrate an RBC cast, it is certainly it's a glomerular origin hematuria, and it is certainly it is a kind of an acute nephritic syndrome. On the other hand, the proteinuria, the quantum of proteinuria is pretty more, so it is a kind of acute nephritic nephrotic syndrome. The differential diagnosis or for an acute nephrotic syndrome in a young boy of this age is, first thing is that post-infectious glomerulonephritis. So the treating group went ahead doing ASO, it was negative, and serum C3 was low, only 17 milligram per deciliter. So the working diagnosis was PIGN, but ASO negative, and there was no sore throat, and there was no focus of infection, and so on. And they went ahead doing biopsy. The biopsy here shows a diffuse proliferative glomerulonephritis. What do you mean by that? The pathology, the glomerular pathology is diffuse here, and there is, as you can see here, there is endocapillary proliferation, and see the entire glomerulus is full of cells, and the Bowman space is almost narrowed out, a slit, and there is mesangial proliferation. The capillary loops are not open. That's why we say it's an endocapillary proliferation. So, and the immunofluorescence, 3+ positivity of C3. And there is a trace, there is 1+ positivity of IgG and IgM, right? So C3 dominance is one of the diagnostic criteria as per Sami Nazar's criteria for diagnosis of infection-related glomerulonephritis as well. So light microscopy also fits well into that, and immunofluorescence also fits well into that. Immunofluorescence in IRGN also, it is now the present diagnostic criteria says that a C3 dominance. Unlike in the past, when a couple of decades ago, when I was a postgraduate in general medicine, the classical post-streptococcal glomerulonephritis pathology used to be more of immunoglobulin dominant, not complement dominant. There has been a paradigm shift in the profile of immunofluorescence in IRGN as well. That by itself is a separate topic. We'll come to that later. Fine. So then the treating team, we went ahead doing electron microscopy. As you can see here, electron microscopy, there are beautiful subendothelial deposits. The red arrow shows that. And there is splitting of the glomerular basement membrane. Okay. And we were eagerly looking for subepithelial deposits, which will tilt the balance of diagnosis towards more in terms of PIGN. There is IRGN. But here, there is no subepithelial deposit. There are more mesangial immune deposits and subendothelial deposits. And this child, on follow-up, the hypocomplementemia persisted. So what is the diagnosis? The diagnosis is C3 glomerulonephritis. What do you mean by C3 glomerulonephritis? This was conceptualized by a great investigator survey in the year 2007. It's a relatively newer disease. It's a relatively newer disease. As the chairperson, Professor Pankaj, alluded to, the defining feature of C3 glomerulonephritis is the dominance of C3 or C3 alone in the immunofluorescence. And the dominance should be at least 2 orders of magnitude more than any other co-immune reactant. That's it. And light microscopy, even though the classical description is the MPGN pattern, membranoproliferative glomerulonephritis pattern. It doesn't mean that all patients with C3GN should have the same pattern. For instance, in our own department series, not even 50% had classical MPGN. Even this child had predominantly a kind of a diffuse proliferative glomerulonephritis. We have also had mesangial proliferative glomerulonephritis, and in a severe form at presentation also you can have crescentic glomerulonephritis and so on. But classically it is MPGN. What is MPGN? It is not a diagnosis. It has been beautifully described by Professor Pankaj again. I would like to repeat it again. MPGN is not a diagnosis. BPGN is not a diagnosis. Even FSGS is not a diagnosis. It is all kind of the mode of injury, the expression of the glomerulus to a particular assault. That's it. So based on that histopathological pattern of the glomerular injury, we have to find out the etiology for the disease. That's how we approach here. And the defining features of membranoproliferative glomerulonephritis, you all know that as the name is itself is self-explanatory. There is a proliferation of mesangial cell proliferation will be there. There will be lobular accentuation of the glomerulus. There you can see, it will be so telltale evidence for the accentuation of the lobularity of the glomerulus will be there. And also the most important thing is that kind of a double contour of the glomerular basement membrane. So that defines the MPGN pattern. And again, MPGN pattern, it's not a single diagnosis. Fine. And electron microscopy, the subendothelial and mesangial deposits. A word of caution here. I was telling that we were looking for subepithelial deposits to make a diagnosis of IRGN. It is not confirmatory. If the prominent subepithelial deposits are there, it is more in favor of IRGN. Absence of subepithelial deposit does not rule out IRGN, particularly if you do a biopsy much later in the clinical course, the subepithelial deposits most of the times it vanish. And similarly, even in a C3 glomerulonephritis, rarely you can have subepithelial deposits. But in general, please remember, if you are able to demonstrate very prominent subepithelial electron dense deposits, you are diagnosed more in terms of IRGN. As simple as that. So this is what is C3 glomerulonephritis. Let me move on to the case winner 2. I'm very glad to share with you in the November issue of 2020, the current month's issue, latest issue of Kidney International. This publication was accepted. It has come out in print. This is again our patient. We just I made a grand round one day, and my registrar presented this particular gentleman as a kind of CKD. But clinical examination, when I looked at, there was something very different. There's a hollowing of the cheek. There's an atrophy. Normally, this kind of atrophy we do see in extreme degrees of malnutrition where there is alcoholic cirrhosis and so on. And two, the patients with the retroviral infection, HIV, particularly on stavudine, and that causes atrophy and so on. There is very few differential diagnoses for this kind of pattern of lipoatrophy of the cheeks. So this situation, we thought something very interesting. So this is what is the presentation. As you can see here, microhematuria and significant proteinuria and renal failure of more than 3 months duration and hypertension. He presented to us with edema and oliguria. So we went ahead doing kidney biopsy. Already the kidneys were borderline kidney size and so on. So this is what, as I've already said, this is kind of a simple mesangial proliferative glomerulonephritis in him. And what was immunofluorescence? Immunofluorescence was only C3. There was 3+ intense positivity. Intense positivity, as you can see here, there is kind of a wavy pattern. And so this itself, we suspected this diagnosis, and electron microscopy ultimately confirmed the diagnosis. What is this? As you can see here, the pitch dark, blackish, asmiophilic, linear, band-like electron deposits right within the GBM, glomerular basement membrane. So it's nothing but dense deposit disease. So the dense deposit disease with association with lipoatrophy, we'll discuss that later. So now this is what is the two phenotypes of this disease, the C3 glomerulopathy. There are two important prototypes. One is C3 glomerulonephritis, where the deposits are subendothelial and mesangial. Whereas dense deposit disease, it is the electron dense deposits. The immune deposits are right in the middle of the glomerular basement membrane itself. Are these two only the entities coming under glomerulopathy? No, more and more entities are getting grouped under the broad heading. The most important is the complement factor H-related gene 5 nephropathy. We'll discuss about that later. And there is an entity called atypical PIGN. Whether it is going to be included in C3 glomerulopathy, we'll have a discussion on that. Fine. So this is what is happening. As I've already said, the most important factor that is at fault here is that so the regulators, the activity of the regulators or inhibitors is reduced, you have the C3 glomerulopathy. Or there is activation of the promoters, you have this C3 glomerulopathy. Either of the two has to happen. So the regulators should go down. So the loss of function mutation of factor H. Normally the factor H acts here, acts on the C3b. And what is the role of factor I? Normally factor I converts the C3b into IC3b, inactive C3b. If it is done, the C3b will not enter into this amplification loop of forming further C3b. Okay, so that's how it is acting. So please remember this pathway, this sequence. What happens is that normally factor I converts the C3b into IC3b. That gets cleaved into C3dg and C3c, and C3dg becomes C3d and C3g. It's all kind of complement debris, lot of debris, normal debris spot. Okay, fine. And there are certain inhibitors of the membrane attack complex, and they are metronectin and clusterin and so on. Okay, so this is what the mechanism of the regulators. Okay, so this is a point of interest here. Why some people develop dense deposit disease and why some people develop the C3 glomerulonephritis. There is one explanation here. Just remember the previous slide. The C3b is inactivated to inactivated by the complement factor I into IC3b, right? IC3b and the further debris are deposited in the GBM. So deposition of IC3b is critical for DDD. So DDD cannot occur in CF complement factor I deficiency. It does not happen. Get the point? Okay, this is a point of interest. This is purely academic. It's not going to have a say on your treatment or something like that. It is for those who have an extra academic interest on the pathomechanism. Whatever I said now, this picture beautifully says that, C3GN and DDD, this particular author says that complement debris diseases, they are not immunoglobulin, they are not immunocomplexes. They're not even a normal complement. Actually, they are products of activation, exaggerated and atrocious activity. That's the adjective I would like to use. What has to be so mild and gentle, here it assumes tsunami proportion. That's what's happening here. There's a lot of debris and that get deposited, and that ultimately results in the disease. See here, IC3b that causes DDD. Membrane attack complex, the terminal components, predominantly they cause C3GN. This is a beautiful explanation of why some people develop one prototype, why some people develop the other one. Fine. So what are the various pathomechanisms by which this can happen? Simply to simplify that, I've already said there is reduction in the inhibitors and increase in the promoters. So by various mechanisms, all this can happen. One, forget about all this. You just remember these two things. One, there can be an element of autoimmunity, or there can be an element of genetic mutations. Broad classification of the pathomechanism. Okay. What is this antibodies? Antibody to the factor H or I or B. So there is a reduction in the activity of this autoimmune disease. Whereas here, antibody to C3 convertase. You might think that C3 convertase antibody is going to do good only. It is going to reduce the activity. But unfortunately, this antibody is a kind of augmenting antibody or a stimulating antibody. As you get an antibody in Graves' disease, so where the antibodies enhances the activity. In fact, the C3 nephritic factor, I said no, the C3 nephritic factor is a C3 convertase of alternate complement pathway. That is a C3BBB. It is in a kind of a fluid shape and its half-life is much less. When there is an augmenting antibody, that is what is a C3 nephritic factor, that stabilizes that and it prolongs the duration of action of C3 convertase, and that results in it. So the antibody, again, there are two different types of antibodies. And all these are mutations. The loss of function mutation of the inhibitors and the gain of function mutation of the promoters. All these happens. So this picture nicely describes the sequence of these things. Then further what happens? Once this complement activated, how does it cause injury? See, these are the phases. There is an injury to start with. There is an injury here. This is the endothelium, this is the GBM, and this is the podocyte and the slip diaphragm. As you can see here, there is the complement fragments are here, and the membrane attack complex is sitting on the GBM and causing injury, increase in the pore size of the slit diaphragm and so on. This is the first phase. And then the proliferative phase. This is the beauty of glomerulus. For instance, in liver, If there is an assault on the liver, what happens? The hepatocyte goes in for necrosis. The cell dies here. But how? Look at the glomerulus. It has got so much of resilience. No, it gets irritated whenever there is an assault on it. It shows its anger by proliferation. So the proliferation here is the pathology, primary pathology. Most of the glomerular diseases where the injury, of course, we do have podocyte loss and so on, but actually the proliferation is the primary mode of response of glomerulus to an injury. As I've already said, the C3A and C5A, the anaphylatoxins, invite the monocytes and neutrophils into the picture, and they liberate a lot of cytokines and chemokines. They cause endothelial dysfunction, endothelial injury, the injury of the glomerular basement membrane. And the third phase is the reparative phase. As you can see here, the new layer, new GBM is laid down. That explains the beautiful description of the double contour, which Professor Pankaj nicely explained. So this is a classical, ultimately what results in, there's a proliferation of the cells as well as there is a double contouring. So this is what is happening. So ultimately, the injury, glomerular injury is mediated by the complement and the cascade. Fine. So this is the current classification of MPGN. As ever initially in the past, I learned when I was a registrar in nephrology, MPGN type 1, type 2 and type 3 and so on. Type 1 is the immune complex where there is a subendothelial deposits in the electron microscopy, and type 2 is dense deposit disease, and type 3 is both subendothelial and subepithelial electron dense deposits and all. All that is gone now. Now it is C3 alone. If it is C3 alone or C3 dominant, it's all C3 glomerulopathy. If there is concomitant immunoglobulin, there is a different panel of diseases you have to work up. For instance, hepatitis B associated, hepatitis C associated, even SLE, and so many other things. You have to rule out all those things. So you have to find out in an MPGN pattern in the immunofluorescence whether it is C3 alone or C3 dominant or along with immunoglobulins. So that is the current classification. All this happened, all this revolution in the thinking and concept happened in 2000, around 2007, 8 or something like that. So how to go about the investigating the patient, okay? So as it has been already pointed out, we don't have this kind of a lab, and I place on record my profuse gratitude on behalf of the entire Department of Nephrology, Madras Medical College, for the great help that is offered by All India Institute of Medical Sciences. Whenever we do get a kind of atypical HUS and we send the sample over there and they do factor H antibody totally free of charges and so on. And thanks to you, sir, your team. Fine. So this is the array of investigations that one has to ideally do. Measurement of the serum complement protein. This we do complement factor C3 and complement factor HIV and so on. C3 nephritic factor presence and other autoantibodies, C complement factor H and B, and quantifying the MCP CD46 expression and the complement factor 50 and AH50 activity. And screening for mutations, complement factor H, I, and so on. And now there are some genetic labs in Chennai itself, and we are able to do some things in the case which we had on the dense deposit disease we published in Kidney International had some problem with this complement factor H related gene 3 to 5. There is a deletion mutation. Okay, fine. It's very difficult to do the complete panel. So as it has been pointed out, one practical way of approaching this is that you have a suggestive histopathology and C3 dominance in the immunofluorescence, and with or without, ideally the electron microscopy has to be done because that settles the issue if it is a dense deposit disease. Other words, if there is persistent hypocomplementemia beyond 12 weeks, think more in terms of C3 glomerulopathy. If the complement gets normalized, you are more in terms of immune-related, infection-related glomerulonephritis. Again, we may be proved to be wrong. This statement is, I'm not asserting on this statement. This is a kind of a practical approach, that's all. Because, there are so many ifs and buts. We'll discuss, we'll come to that later. Fine. A few words about dense deposit disease, and this is the onset of dense deposit more in childhood and young adults. Predominantly, a lot of papers from the pediatric nephrology. It's a disease of basically pediatric nephrology in young adults and so on. And presentation of C3GN and dense deposit disease, it's highly heterogeneous. It's a wide range of clinical presentation. On one end of the spectrum, you have very asymptomatic mild hematuria and microhematuria and proteinuria, subnephrotic proteinuria on the one end of the spectrum. On the other end of the spectrum, a representation itself as kind of rapidly progressive renal failure with rapidly progressive glomerulonephritis and so on. You can have anything. And again, I've said pathology also. predominantly MPGM, but it can have a mesangial proliferation and diffuse proliferation and so on. Fine. So the clinical picture is so varied. So naturally, the natural history, there is a difficulty, inherent difficulty in studying the natural history of these two entities and so on. Whatever natural history we are projecting, it is a published experience of some centers. It may not be the real natural history, because the milder forms may simply escape our attention itself. So it is so, and again, these diseases we are dealing with only some 1.5 decades. So still, what remains to be learned and known is much more than what has already been learned and documented. Okay, you can have partial lipodystrophy. Why there is partial lipodystrophy? Because this lipid lysis, the lipid lysis, the fat lysis, is complement mediated. Why partial? Why partial? Only those adipocytes which are expressing a protein called adipsin, they are vulnerable to get lysed by complement. That's why it is partial lipodystrophy. Similarly, you have to look into the fundi, ocular fundi, where you can see the drusen. What are these drusen? Lipoproteinaceous deposits containing complement. The complement fragments deposited in the Bruch membrane of the retina. That's what is. And some patients, they have demonstrated insulin resistance. A very important point in adult nephrology is that whenever you come across either C3GN or particularly dense deposit disease beyond the age of 50 years, it is mandatory that you have to rule out paraproteinemia, starting with the multiple myeloma to the whole range of it. Monoclonal gammopathy of renal significance has to be ruled out. Why mechanism? What is the mechanism? If there is an underlying dysregulation of alternate complement pathway, this paraprotein can act as a trigger on that, and it can bring it to surface. And again, making a diagnosis of paraproteinemia is very important, because your therapeutic approach is going to be different. Okay, that's it. But that doesn't apply. I mean, it's not a major issue in pediatric practice. Okay. And in C3 nephritic factor, the presence in dense deposit disease is much more common than in C3 glomerulopathy. And again, it is not specific for dense deposit disease. And there are instances where C3 nephritic factor has been documented, even immunoglobulin dominant MPGN pattern and so on. But in dense deposit disease, up to 70 to 80% of the patients, you can demonstrate the dense deposit disease. The C3 nephritic factor. What is the C3 nephritic factor? As already said, it's an IgG autoantibody. It stabilizes the C3 convertase of alternate pathway. Okay, so there is excessive activation. The problem is that it's, as I've already said, it's not very specific. It's also present in some normal individuals and in certain infections, particularly due to meningococcus and so on. It's not 100% specific. Okay, if it is there, it's fine. That's all. So the natural history, according to one published series, it is a series of 27 patients, and 7 patients went in for ESRD and so on. In general, what they say is that over a period of 5 years from diagnosis, both C3GN and this thing, 50% of them going for end-stage renal disease. It's not a good disease. It's not a good disease with good prognosis and so on. Okay, so this is a kind of one syndromic diagnosis also there, where there is DDD is a component of it. The Dunnigan-Koberling syndrome with acquired partial lipoatrophy and C3 nephritic factor presence and lysis of adipose tissue, associated insulin resistance and so on. Okay, then the third component of it, the complement factor H-related gene 5 nephropathy. It was first described in 2 families of Cyprus. It's a familial occurrence. Okay, both the families had common origin. It's a kind of an autosomal dominant this thing, and abnormalities in the complex of complement factor H-related protein 5, the gene 5, and okay, it normally inhibits the C3 convertase. If there is a deletion mutation, loss of function mutation, there is an enhanced activity on the C3 convertase, and they present with microhematuria. To make things worse, sometimes C3GN, the trigger, it is waiting for some trigger. There can be a presence of dysregulation of alternate complement pathway, but not all of them develop the disease. A trigger like an infection, classically even a pharyngitis can. So that makes things all the more difficult to differentiate between IRGN and your C3GN. Right? And how to treat. This is initially, for instance, in our own unit, we were very nihilistic in the initial years. Because there was a lot of discouragement of starting any immunosuppressants in patients with the C3GN, thinking that it will not do any good at all. Initially, once we make a diagnosis, we never ventured with any kind of specific treatment. But anyhow, the general measures certainly we were doing, like strict control of blood pressure. There is edema, fluid restriction, and salt restriction. In adults, keeping a target blood pressure of 120/80, particularly with AC inhibitors and ARBs because they are rhinoprotective as well as antiproteinuric. And statins, if there is persistence of dyslipidemia and persistence of proteinuria, statins was given general measures. And from many centers, they started treating in their own way of with steroids or steroid plus MMF or in severe forms with cyclophosphamide and so on. But nobody could really document any benefit initially. And as I've already said, in particular, there are certain pediatric units as well as in adults with monoclonal glomerulopathy. There was some experience from centers with positive impact with plasma infusion, 10 to 15 milliliter per kg every 14 days, and which was continued for 6 to 12 weeks. And if there is response, good response, to continue forever and so on. There are beautiful reportings. But later on, but this kind of therapy has not been validated. It has not come as a kind of a guideline. It's more of a kind of experience. And similarly, C3 nephritic factor, there are some centers where even they have done plasma exchange to reduce the activity of C3 nephritic factor and so on. But it does not come as a guideline. Fine. Then the specific treatment, so it is mediated by complement. Then people thought, why don't we apply the anti-complement drugs? And we had experience of use of an anti-complement drug even in the treatment of paroxysmal nocturnal hemoglobinuria. So that's what kind of induced some investigators to think in terms of eculizumab. Eculizumab is kind of a humanized monoclonal antibody which acts on the complement component C5. But this is, as of now, this is the costliest drug on the earth. Ordinary man cannot afford this eculizumab. Eculizumab, to start with, it was used in thrombotic microangiopathy to start with, and there was good response with eculizumab in certain patients with HOS, atypical HOS and so on. That prompted people to think in terms of use of the same drug in C3GN as well. But it is not a simple drug to use. It's so important because, anything, if you want to meddle with, complement, as I already said, is a very, very strong component of your innate immunity, and you are in trouble, particularly encapsulated organisms, infections with encapsulated organisms, classically meningococcal infection and so on. The infectious complications can take a heavy toll, even on the cost of it. So it is not easy. It's not a joke to meddle with complement. So people wanted to have a real solid evidence for the benefit of eculizumab if it has to be incorporated as a regular kind of a treatment protocol. So this is what is the mechanism of action of the eculizumab here, like C3 further progression of the C5 doesn't happen with that. Then people thought, since it acts much distally, only the subset of patients in whom the plasma levels of MAC is elevated, in such patients only let us use. That's what they said. Why? Because, initial reports were not very encouraging. The response, the positive response to eculizumab is not even 50%. Then they started thinking in terms of the subset of patients in whom the membrane attack complex levels are elevated because it acts much distally. So then people thought, why don't we develop anti-complement drugs which act more proximally? But please remember, any drug which acts on more proximal components of the complement, the complications are going to be many, many fold. It is not a joke at all. Unless you have a very strong evidence, we should not venture there at all. Then, as ever, it has been pointed out already, these patients progress to ESRD, and what about transplant? Transplant recurrence rate is pretty high. Why? Because you have kept a new kidney, but the dysregulated complement pathway still remains the same. So the grafted kidney is likely to get affected. The recurrence rate is to the tune of 65% in C3G and to the tune of even 100% in DDD. This has to be explained and counseled to the patients before embarking on transplant itself. So where do we stand on treatment of C3 glomerulopathy? Now the recent literature gives a kind of a better guidance for us. first thing is that there is no definitive treatment of proven benefit that we have to be aware, number one. Number two, as I've already said, general supportive therapy of BP control and statins. Specific therapy again, immunosuppressive drugs or anti-complement therapy, or both in sequence. So this is the strategy, right? You have to go for specific therapy, either immunosuppressive therapy or anti-complement therapy, only in patients where there is heavy proteinuria and progressive decline in the GFR and persistent microhematuria. Milder forms, you have to apply only the general supportive measures and keep a close watch on the patients. This is a very, very important observation. It throws a lot of light on how to treat C3 glomerulopathy. The GLOSSAN is stands for the Spanish group for the study of glomerular disease. The study is a very important study. It's a landmark observation, I would say, even though it is only a retrospective study. It is not an RCT, not at all. It is only retrospective and a multi-center cohort study. So it's not an RCT study, but the kind of information or the direction it gives us is of immense help. What is that? What is so great about it? It is a study of about 97 patients with biopsy-proven C3G studied over a period of 25 years. And how they analyzed the determining the results and so on, the multivariable and propensity scoring analysis. They studied two things. What is the remission rate? What is the kidney failure rate? As you can see here, out of these 97 patients, the 42 patients had been on steroids and MMF. And then the remission was as high as 80%. And renal failure progression only 14%. In sharp contrast, the centers who decided not to treat at all, because I have said no, many centers like us, we were nihilistic in the past on C3GN. The remission rate was spontaneous remission. Please remember, there are milder forms which can go in for spontaneous remission as well. 18%, but kidney failure 65%. Other immunosuppressives like CNIs and other things, the remission 24% and kidney failure 59%. Eculizumab, the costliest drug on the earth, it induced remission only in 1/3, and kidney failure in 2/3 progress too. This opened the eyes, let us not jump and try to give anti-complement drugs in every patient. So now I'll put my money in the group of steroid and MMF. It has almost become a kind of a guideline. It's evolving to kind of a guideline. Fine. And also there is an argument whether there is difference in the response to therapy in the subset of the patients in whom the pathogenic mediator is autoantibody, that is autoimmune phenomenon, or is it a genetic mutation? Is there any difference? According to this study, those who had autoantibody, for instance, antipeptide antibody, C3 nephritic factor, and so on, there are numerically more patients went in for complete remission compared to those with genetic defects. But even those with genetic defect associated C3 glomerulopathy, it is not a contraindication for your therapy. It is not a negative predictor of outcome. Even a significant number of that category where there is a genetic mutation of the components of the alternate complement pathway also benefited with this, even though the number is more in autoantibody possibility. This is a very important point to remember. Just because you demonstrated a mutation in a gene, don't come to a conclusion that none of your therapy is going to be of benefit. Don't do that. And another important point this study has shown is that in those who had remission after discontinuation of therapy, there was a relapse in 1/3. So this gives another guideline, another point of importance that your therapy has to be little prolonged. So now this almost the standard of care has become steroid plus MMF, and the duration we don't know exactly, but preferably have it for a prolonged period. And this is, I would suggest everyone, please go through this nice article coming in the latest issue, November 2020. There is a practical management of C3 glomerulopathy and immunoglobulin-mediated MPGN facts and uncertainties. This is a wonderful article, and this highlights the kind of the complete management of the entire spectrum. I will not repeat all this. This we have already kind of the step number 1, C3 glomerulopathy and immunoglobulin associated MPGN, and you have to rule out all these infections and other causes and so on. Here you have to rule out post-infectious glomerulonephritis. How? Persistent hypocomplementemia or normalization of the complement. Okay, that's it. Then, it's a kind of a gross differentiation. Then in adults, more than 50 years, you have to rule out monoclonal gammopathies and paraproteinemias and so on. This is the first step number 1. Then you do complement workup, right? And step number 3, when there is, in case of subacute or acute deterioration of serum creatinine and or proteinuria, you have to consider repeat kidney biopsy. And now they are evolving kind of a scoring system. There are 7 components to decide on the activity and 4 components in the deciding the chronicity. Why? If you do a kidney biopsy, if the chronicity is more, don't subject the patient for any definitive therapy. So that is the idea. Okay. Then in those with mild proteinuria, less than 1 to 1.5 gram per day, and stable serum creatinine, only supportive therapy with RAS inhibition, and keep a close monitoring of the renal function and the proteinuria component. Only those patients where there is heavy proteinuria, more than 3 gram, they are in a nephrotic syndrome, or acute or progressively rising serum creatinine, and kidney biopsy, there is no gross chronicity. There is less than 30% IFTA. Then you think of immunomodulated treatment. The current therapy is mainly inflammatory component of C3, that is the steroid and MMF, right? The first line is steroid and MMF. Duration has to be at least 12 to 18 months. You can taper, but keep a very close watch while discontinuing, because 1/3 of them going for relapse. Okay, there is no definite evidence for other immunosuppressants. The second line only is the anti-complement therapy. There can be a potential benefit possibly with this anti-complement therapy in crescentic forms of therapy, or while on this first line therapy, still there is a progressive rise and so on. So this gives a kind of a practical approach to C3 glomerulopathy. And also another important, finally, just a couple of points I would like to say that the same defect, factor H mutation, why some people develop TMA while there is a atypical HUS, while the other people develop C3GN, actually the complement regulatory region and the endothelial cell binding region, the C terminal and the N terminal. It depends on which terminal, which component of factor H goes in for mutation, that decides the pathology. Okay, but there are instances where the child might have had atypical HUS, and then there can be some treatment and recovery and all that. Later on, as during adult life, presenting as C3 glomerulonephritis, we also have seen. So there is a lot of overlap and so on. Finally, the last slide here, as I was telling, we think that IRGN, the post-infectious glomerulonephritis, or IRGN and C3GN are totally different entities. Now there is more and more evidence accumulating that both of them are kind of representing different points in the same continuum of disease. Normally, what happens is, there is one hypothesis. This is promoters and regulators of alternate complement pathway. This is normal. When there is infection, the tilt and balance. So there is activators gain upper hand, that results in the glomerular pathology. And after some time, if the balance is brought back, there is recovery. Okay. When we call it as atypical PIGN, when there is persistence of the proteinuria, hematuria, and the elevated creatinine, and azotemia, and so on, either a slow recovery or no recovery at all, because this balance is not brought back at all. That results in a kind of atypical PIGN. Now we know this is a kind of, this represents probably a C3. That's why initially I said the prototypes are C3 glomerulonephritis and DDD, and the other diseases also are going to change. And in fact, there is a lot of evidence accumulating. For instance, recently there was a JASN paper where about 40% of the patients with PIGN, there was anti-factor B antibodies and so on. So with this, I stop here, and thank you very much for the wonderful opportunity.
Thank you, Dr. Gopalakrishnan, for a very nice presentation. You very patiently explained the whole pathogenesis of C3G, including the dysregulation of alternative complement pathways. So we will take questions now, and in the chat box, I can see that there is one question.
We'll take up the questions at the end of the session, sir. Towards the end of the last.
Okay, you want the questions to be taken after?
Yeah, after
okay,
the.
Yeah. I don't know whether I've exceeded my time limit. I couldn't see my time. Sorry for that if I have exceeded.
No, not an issue at all, sir. It was an excellent job. No, sir, no, not at all, sir.
All right, so we move on to the next presentation, and that is on lupus nephritis. And just brief background about lupus nephritis. SLE is not such an uncommon disease in adults, and in hospital practice, one would see a lot of adult patients with SLE and lupus nephritis. And this disease is also not so uncommon in children. However, this disease differs from what is there in adults. The children suffer from more severe disease. More proportion of patient would suffer from lupus nephritis or renal involvement, and the renal involvement or lupus nephritis that is associated with poor outcomes in terms of progression to CKD, ESRD, as well as mortality. So this is we were able to follow up patients of lupus nephritis at our center, and where we found that in fact patients who had class 4 nephritis, lupus nephritis, they did fairly poorly as opposed to the other classes in terms of renal survival. And overall, the renal survival was 3 years. Over three-year renal survival was about 92% in a cohort of patients where we had about 54 patients. And sepsis was also a very important cause of mortality in our patients. So it's very important that when we give immunosuppression to these children, one has to be careful about over immunosuppression, which can result in infections and septicemia. Another unfortunate thing in lupus nephritis is that most of the treatment is extrapolated from adult trials, and the paucity of pediatric trials is because the disease not been so common, and we really need to collaborate to have multicentric studies, and that are lacking in children. Because of on the basis of those large multicentric trials in adults, they have shaped the current guidelines on treatment of lupus nephritis. They have several guidelines available: EULAR, the SHARE, CARA is the pediatric guideline, Spanish guideline, KDIGO, etc. I'm sure Dr. Zubaida, your next speaker, is going to be presenting and discussing them. As far as the issues with treatment of lupus nephritis is concerned, it is now fairly accepted that for the induction in proliferative lupus nephritis, IV methylprednisolone 3 doses is a standard of care. However, there is still debate about using and trying to use as low as a dose of oral daily steroids as possible to induce remission. So there are recommendations for using much lower doses as opposed to what we were doing in the past. IV cyclophosphamide is a standard of care for inducing remission. However, mycophenolate mofetil has been shown to be promising. It is at least been shown that not to be inferior to IV cyclophosphamide, and people are gradually switching over to this drug. And I'm sure this will be discussed in the forthcoming lecture. Another therapy for induction which has shown promise is a multi-target therapy, which is a combination of low dose of tacrolimus and mycophenolate mofetil. However, the trials of this therapy has been limited to the Chinese population. It has to be, we have to have more data where it become more generalizable to the other populations as well. As far as the role of monoclonals is concerned in lupus nephritis for induction, people had a lot of expectation with rituximab. However, initial studies wherein rituximab was added to the standard of care therapy, rituximab did not result in much of benefit. Very recently, a monoclonal antibody against the Bliss protein has shown to be effective, which is called belimumab, which there has been a recent publication in NEJM where this drug has been found to be beneficial in terms of inducing remission over standard of care therapy for lupus nephritis. And then there are other issues of how to define refractory disease, how does one define response in children, how long to continue therapy, 5 years or longer. So all this will be discussed by our next speaker. And for this talk, we have Dr. Jubaida Rumana, who is a pediatrician from Bangladesh College of, and she's been an IPNA fellow in pediatric nephrology from St. John's. Currently at Asghar Ali Hospital, she's an associate consultant of pediatric and pediatric nephrology in Dhaka, Bangladesh. Specific academic interest is in renal critical care, transplantation. She has several publications on different reputed journals, published several papers, conducted workshop on renal replacement therapy. So now I would invite Dr. Jubaida Rumana to make the presentation on lupus nephritis. Dr. Jubaida, please.
Thank you, sir. Am I audible?
Yes, yes, you are.
Yeah. Yes. Thank you for your nice introduction and your brief presentation on SLE. Today, my topic of presentation is on childhood vasculitis, and I'm mainly focused on. I'm going to mainly focus on primary systemic vasculitis. I don't know why the slides are not coming.
No, 1 second. I'll just play your slide. Yeah.
Yeah, it's okay now, no?
Yeah, it's fine.
Okay. So my heartfelt thanks to Dr. Kalaivani and the organizing team of Mehta's Children's Hospital for inviting me in this webinar series. It's really an honor for me to be here with you all. And my topic of presentation is today childhood vasculitis. And over the next 35 to 40 minutes, I will focus on following points. All childhood vasculitis is not equally common in case of children, and the incidence rate is widely varies. So today I'm going to present accordingly to most common variety to less common variety of vasculitis in case of children. Vasculitis is an umbrella term for various heterogeneous disorder sharing presence of inflammation in the blood vessel. This inflammation may cause vessel wall thickening, stenosis, and occlusion with subsequent ischemia. Sometimes the necrotizing inflammation can completely destroy the segment of the vessel wall. So this inflammation of the vasculitis can occur from primary systemic process, and also it's from some secondary vasculitis. Secondary causes like infection could be viral, could be bacterial or fungal. Some malignancy can cause vasculitis like lymphoma and lymphoproliferative syndrome, and autoimmune cause like SLE, which is discussed by Dr. Pankaj sir, and GIA and juvenile dermatomyositis. Some medication can also cause vasculitis like tumor necrosis factor blocker, antithyroid drug. And recently emerged monogenic vasculitis, which is a single gene disorder which have features of vasculopathy in the skin and other organ is identified. The classification of primary childhood vasculitis is still an ongoing challenge due to its clinical phenotype. It can involve single organ to multiple system. Also the involvement of different size of the vessel like large vessel, medium or small, and also the histopathology with immunoinflammation with like granulomatous or non-granulomatous. So in the year 2012, Chapel Hill Consciousness Conference have classified with the association with Euler and Press classification. They have mainly classified childhood vasculitis into three major forms. One is large vessel vasculitis, second is medium size vasculitis, and small vessel vasculitis. Small vessel vasculitis is further divided into immune complex mediated and ANCA associated vasculitis. So here we are saying there is overlapping of the blood vessel size also, and the involvement of the organ and clinical type is not depending on the size of the vessel. So it's how the patient of vasculitis can present to us. It's also depend on the location of the vessel, the extent of the damage and surrounding area, and the hemodynamic status of the child. So if there may be some constitutional symptom like fever, malaise, weight loss, some arthritis or arthalgia, some skin manifestation could be there like palpable purpura, urticaria, and respiratory complaint like epistaxis, hemoptysis. And if there is involvement of the cardiac and pulmonary area, patient may present with us to cardiac failure and pulmonary failure. And to us, the renal patient, sometimes when there is renal involvement, patient may present to us with urinary sediments and impaired renal function. So before going to case-based discussion, I'm just outlining the principal management of vasculitis. So it's a very important point to us to differentiating vasculitis from other disease, which sometimes this primary systemic vasculitis mimic with other vasculitis and some secondary cause of vasculitis. Like if the vasculitis is due to infection cause and we are giving immunosuppressive, this will be catastrophic. Second important point to know the disease activity and severity of the disease. There is no objective evidence and also no reliable marker to know the disease activity. It solely depends on the clinician judgment and some indirect marker of inflammation like CRP, ESR, and platelet count. And third point is the weighing the benefit and risk of the therapy. It is also very important to provide maximum benefit to the children. So according to the stage of the disease, we have to decide about induction therapy to stop the inflammation, to maintenance therapy for maintaining the remission, and relapse therapy when there is further recurrence. And another point is refractory therapy. Some vasculitis are like persistently the inflammation is present or the worsening features are there. And in that case, we have to alter the therapy or we need to add on another immunosuppression or biological agent. So now I'm going to present one case. This is a very common case to our daily practice. It's a 9-year-old girl having palpable purpuric rash, mostly in the lower limbs, and she has puffiness of eyes for 3 days. She's complaining for mild abdominal pain, and on examination, there are non-blanching palpable rash with edema, and the child was normotensive. And urine RE shows microscopic hematuria with proteinuria. Our other normal she's having normal renal function. C3 and IgA was normal, and spot protein creatinine ratio was in non-nephrotic range. So skin biopsy was done, which is showing leucoclastic vasculitis with infiltration of the neutrophils, and on immunofluorescence there is deposition of IgA. So it's the diagnosis of IgA vasculitis nephritis. IgA vasculitis nephritis is the most common form of childhood vasculitis, which is immune complex mediated, and it has some association with prior infection 2 to 4 weeks before. The trigger mechanism is still unknown, and there are some IgA deposition in the vessel wall, which cause activation of the complement cascade, and it causes tissue inflammation and edema. Sometimes the mast cell and basophil degranulation is there, causing vasodilation and edema, and recruitment of the immune cell causing tissue inflammation. So for the diagnosis of IgA vasculitis, the diagnosis of IgA vasculitis, there is a mandatory criteria according to Euler, Pinto, and Press. The palpable purpura should be there in 10% of cases, and purpura will be like symmetrical and following gravity. There is absence of any thrombocytopenia, and plus any one of the following like GI symptom with mild abdominal pain to severe abdominal pain with perforation-like feature or intersusception can be there. Kidney involvement could be there with proteinuria, hematuria, hypertension, or nephritic or nephrotic-like features. There could be joint involvement like arthritis or arthalgia. And if we do the histopathology in the skin, it will show leucoclastic vasculitis, and in the kidney, proliferative glomerulonephritis with IgA deposition. Management depending on the area of involvement and the severity of the patient. And if there is only the skin manifestation and joint manifestation, treatment will be like symptomatic treatment. In GI cases, there are a role of a short course of steroid, though there are some controversy. And for the IgA vasculitis nephritis, there are some protocol-based treatment. So it's a nice review on April 30, 2020. You have focus on the management of IgA vasculitis. So according to the KDIGO guideline of 2012, they have recommend the treatment of HSP nephritis as if the patient having mild proteinuria like 0.5 to 1 gram per meter square, they should be treated with ACE inhibitor or angiotensin receptor blocker. And the patient who is having persistent proteinuria more than 1 gram per meter square, and those who have failed on the angiotensin converting enzyme inhibitor and the renal dysfunction is there, they should be treated with corticosteroid with a 6-month protocol. And the patient need to do biopsy if there is features of nephrotic syndrome and persistent proteinuria or renal dysfunction. And if the biopsy is showing crescentic glomerulonephritis in 50% of the glomeruli, the patient should be treated with steroid and cyclophosphamide. It is very similar to the treatment of the IgA nephritis. Even in 2018, KDIGO has updated the treatment protocol according to the evidence of summary in patient with IgA nephropathy and IgA vasculitis nephritis. There they have shown that the corticosteroid versus placebo or supportive therapy has a very minimal role to prevent the severe kidney disease. And the patient who is having HSP nephritis with severe kidney disease, the role of cyclophosphamide with versus supportive therapy is still not proven. And other drug like cyclophosphamide, cyclosporine, mycophenolate mofetil, also the efficacy of this drug are not clear. And in 2019, again, KDIGO guideline have considered that treatment of steroid can reduce proteinuria, but its role to prevent renal dysfunction is still controversial. Another guideline of SHARE guideline, which is in 2019 updated, and it has in compared to KDIGO guideline, they have mentioned that the early initiation of ACE inhibitor and steroid in case of mild to moderate proteinuria, they have considered, and the patient should be in follow-up. And the patient who having severe proteinuria or impaired glomerular filtration and having persistent proteinuria, renal biopsy should be done in these cases. They have defined persistent proteinuria into 3 categories. One is if there is a proteinuria for 250 milligram per protein creatine ratio is more than 250 milligram per millimole for 1 month is persistent. But if there is moderate proteinuria like 100 to 250 for 3 months and mild proteinuria more than 50 milligram for 6 months, they should be also defined as persistent proteinuria. So all these cases need renal biopsy. And according to renal biopsy, if there is mild nephritis, the first line therapy is with oral corticosteroid and second line with azathioprine, mycophenolate or pulse methylprednisolone. And the patient who is having moderate nephritis, like they have crescent less than 50% and impaired renal function, should be treated with oral corticosteroid with pulse methylprednisolone. And on the second line, they have to use azathioprine, mycophenolate, and IV cyclophosphamide. And in severe nephritis patient, those having crescent more than 50% cases, they should receive cyclophosphamide with pulse methylprednisolone. They also recommend that the use of oral cyclophosphamide and calcineurin inhibitor has no role at all in this IgA vasculitis. Some other newer drug like budesonide formulation, eculizumab, narsoplimab, and rituximab has some study ongoing and phase 3 trial. And also there is role of plasmapheresis. The patient who are not responding to cyclophosphamide or pulse methylprednisolone, they get better with 10 to 12 session of the plasmapheresis. The second case scenario I'm going to discuss is in the mid of June, admitted under us in the COVID peak season. This is an 8-year-old boy who have history of high-grade fever for 6 days and severe cough and weakness for 3 days. He has a contact history of COVID-19 patient in his family. And on examination, he has bilateral non-purulent conjunctivitis, fissured lip, polymorphous exanthum in the trunk, and periangual disformation. His SARS-CoV RNA test is positive. He have leukocytosis with lymphopenia. Inflammatory markers are positive with high D-dimer, and hepatic function was impaired. His HRCT showing bilateral groundless opacity in favor of COVID pneumonia. And echocardiography shows left main coronary artery aneurysm with significant dilatation of 4.1 mm. So there is some scattered case report on Kawasaki disease. This patient is diagnosed as multisystem inflammatory symptoms with Kawasaki disease-like feature. So there are some case reports in the different case reports where they have shown there is a association with Kawasaki disease with COVID positive patient. So this is an article which was published on July 2020. There they have done a quasi-experimental retrospective data analysis where they have shown in the year from 2009 to 2020, total 230 patients of Kawasaki disease patient were admitted in that hospital. And there is a peak of Kawasaki disease patient in the year 2010 in the season of H1N1 outbreak, and in 2020 when COVID-19 outbreak is there. So they have concluded as there is an emergence of Kawasaki disease patient with SARS-CoV infection. So Kawasaki disease is the second most common primary childhood vasculitis. This is a systemic necrotizing vasculitis involving mostly small and medium-sized vessel. It's also known as mucocutaneous lymph node syndrome. There are some genetic predisposition and infection triggers are associated, and their viral etiology is always speculated, but there is no proof which specific viral agent can cause Kawasaki disease. And mostly it is common in less than 5 years of the children, and infants are less frequently, but more severely affected. There is no specific test to diagnose Kawasaki disease. It's depending on the diagnostic criteria according to the Share and American Heart Association, where there is a mandatory criteria of fever for more than 5 days or more, with any four of the criteria like peripheral extremities change or perianal change, polymorphous exanthum, bilateral conjunctival non-purulent injection, and change in the lips and oral cavity, and significant cervical lymph adenopathy. The fever duration is less than 5 days, and any four of these clinical above criteria is positive, and with there is a coronary dilatation, the child is also diagnosed as Kawasaki disease. Another definition of incomplete Kawasaki disease and or atypical, the patient having fever more than 5 days on without any explanation, and any of the 2 to 3 clinical criteria is present, and if there is any laboratory findings or echocardiography findings are positive, this child is also diagnosed as incomplete Kawasaki disease. So for the management of Kawasaki disease, we have to first control the inflammation. For that, IVIG is the drug of choice. We should give IVIG 2 grams per kg in a long infusion of 8 to 10 hours, and start with aspirin, very high dose, 30 to 50 milligram per kg per day, until the child is febrile and and there is a high inflammatory marker. Sometimes the child are not responding to the IVIG and they are marked as IVIG resistant patient. Their Kobayashi score could be more than 5. So in that cases, there is role of corticosteroid as methylprednisolone. And if there is the persistent inflammation is there, so there are some trial of tumor necrosis factor blocker. It shows a good result. Next, to control of inflammation, our point is to prevention of the thrombosis. So if there is a large or giant aneurysm, usually more than 8 mm, so we should first heparinize the child and continue aspirin till the aneurysm is there. And if there is a small aneurysm, we should continue aspirin in a low dose until there is coronary dilatation. And this child should be of Kawasaki disease should be in long-term follow-up, because there are issues of cardiac morbidity, and the children who are not having any coronary artery changes, they may develop coronary artery change in later on. And if this is the most common acquired cause of cardiac disease in case of adolescent and young adults. The third commonest vasculitis is polyarteritis nodosa, PAN. It's a necrotizing vasculitis. It's also involving medium and small size vessel, and it has 2 distinct forms of systemic and cutaneous. And cutaneous PAN has some association with the streptococcal infection, and there was an association with hepatitis B also, but with improvement of vaccination, we are not finding this. And if there is the systemic involvement, in case of PAN, the multiple organ systems would be involved and its presentation widely varies. But in case of cutaneous PAN, it is less severe and there is some subcutaneous painful nodular non-purpuric lesion with or without livedo reticularis. So for the diagnosis of PAN, there should be one major criteria like histological evidence of necrotizing vasculitis or angiographic dilatation and the angiographic evidence of aneurysm or vessel occlusion. And in minor criteria, there may be presence of skin involvement with livedo reticularis or painful subcutaneous nodule. Patient may have myalgia or muscle tenderness, and arterial hypertension could be there. Patient may have poly or mononeuropathy, and in kidney involvement there are presence of urinary sediment with or without kidney failure. And the management of PAN is still recommended from the adult study. For isolated cutaneous PAN, there is a treatment of choice is NSAID and corticosteroid, and patient should be on follow-up. And if there is a systemic PAN, so we have to induction should be done with high dose corticosteroid with cyclophosphamide or MMF, and maintenance should be continued with azathioprine and MMF. There is a trial MyPAN which shown that there is non-inferiority in between mycophenolate mofetil and cyclophosphamide in case of treatment of induction and maintenance therapy in PAN patient. Now I'm going to discuss on monogenic vasculitis. These are single gene defect disease having features of vasculopathy present in early childhood, which are resistant to conventional therapy. So one is deficiency of adenosine deaminase 2. It's an autosomal recessive inherited disorder. These patients come to us with the features of PAN, like a livedoid rash or ulcerative lesion in the digit, and there are involvement of the arteries of GI system CNS. They may present with early onset of stroke, and the acute fast reactant is high in this patient. And if we do the histopathology, it will show necrotizing vasculitis. So the patient who are having PAN-like features with positive family history of consanguineous parents, early onset stroke, and unexplained hematological and immunological abnormalities there and not improving in the conventional therapy, the ADA2 enzyme level or the genetic test of ADA2 should be performed. And the treatment of this patient, some case reports are there who have shown that the use of anti-tumor necrotic factor agents can help in recovery of the stroke. But if there is hematological or immunological abnormality, stem cell transplantation is the treatment of choice. Another monogenic vasculitis is sting-associated vasculopathy, SAVI. It's also an autoinflammatory interferonopathy where there is high level of interferon, and this disease also starts in infancy. There is a typical telangiectatic lesion in the nose and cheek of the patient, and there is violaceous atrophic plaques on the hand. And the patient may present to us with failure to thrive, polyarthritis, myositis, or muscle atrophy. They may present with ulcerative lesion and tissue loss due to vasculopathy, and it is the key point of feature. And the patient may have some nail fold capillary tortuosity with capillary loss, which causes scarring in the acral area, such as ear cartilage or nasal septum. Sometimes the patient have dystrophic nail change and a resorption of the fingers and toes with gangrenous disease. They have pulmonary involvement also in a form of interstitial lung disease with hilar and paratracheal lymphadenopathy. And if we do the biopsy, there is a neutrophilic infiltration with karyohexis, and there is fibrin deposition in the lumen. So one case report showed that for the treatment, baricitinib is the drug of choice. It improves the hematological parameters in this child, and I'm taking this picture from the New England Journal of Medicine. It's a case report. Next is the Takayasu arteritis. Though the incidence and prevalence of Takayasu arteritis is very less in case of children, usually girls and young women are affected compared to boys. This is also a granulomatous vasculitis involving mainly aorta and its main branches of coronary and pulmonary arteries. And there is some genetic factor and humoral cellular factor are associated, and presentation may vary from non-specific mild symptom to heart, cardiac and pulmonary involvement or failure. So for diagnosis of Takayasu arteritis, there is a pathology in the angiography, which shows the occlusion or dilatation in the main aorta or main branches of the pulmonary arteries, and any one of the following features like absence of peripheral pulse or claudication, asymmetrical BP, murmur, hypertension, or the systemic inflammatory marker high. And management is dependent on the organ involvement and pre-existing damage. So first line induction therapy with corticosteroid and disease modifying agent, and maintenance should be continued with the disease modifying agent. And if there is they are treatment refractory or acutely life-threatening presentation is there, and they should be treated with tumor necrosis factor inhibitor, interleukin 6 inhibitor, or rituximab. And there is also some role of surgical intervention who are hemodynamically unstable. Their vessel stenosis is there, so surgical intervention may needed, but it's also discussed that it may promote inflammation. So here in this literature review, there are 84 patients of refractory Takayasu arteritis who received anti-tumor necrosis factor. Among the 84 patients, 4 were children whose median age was 11.5 years, and they received infliximab, and it causes 37% complete remission and 53.5% of partial remission among these 84 patients. But there is a side effect like infection and hypersensitivity is there, and infection like viral reactivation, histoplasmosis, tuberculosis are there. So in 8 patients, they have to discontinue infliximab among 84 patients. In this figure, we are showing that after starting of anti-tumor necrosis factor, there is significant reduction in the dose of prednisolone, and CRP and ESR also significantly improve. Next case scenario is a 9-year-old boy who is having generalized edema with oligoanuria for 2 days and history of hematuria. He has history of high fever and vomiting for last 10 days. He was hypertensive and having features of fluid overload. He has nephrotic range proteinuria and renal impairment. And patient was immediately hemodialyzed, and 5 doses of methylprednisolone was given, and followed with mycophenolate mofetil and oral prednisolone. His ANCA test was positive, and other immunological and serum complement level was normal. Biopsy was done, and it shows post-immune variety of crescentic glomerulonephritis with fibrocellular crescent is 64%. So it's a diagnosis of ANCA-associated vasculitis. Its ANCA-associated vasculitis is a necrotizing vasculitis involving mainly small vessels, and there is presence of ANCA, which is reactive to myeloperoxidase or proteinase 3. So P-ANCA is which is typically directed against myeloperoxidase, is associated with microscopic polyangiitis and eosinophilic granulomatosis polyangiitis. And C-ANCA is an antibody typically directed with proteinase 3 and associated with granulomatosis of polyangiitis. The ANCA titer doesn't depend on the severity of the disease, and it may be positive in other diseases like SLE, rheumatoid arthritis, ulcerative colitis, and endocarditis. There are 3 main varieties of ANCA-associated vasculitis. One is granulomatous polyangiitis, which is initially known as Wegener granulomatosis. There are granulomatous lesion in the small vessel and also in the upper and lower respiratory tract. So patient may present with the features with sinusitis, hemoptysis. Sometimes there are nasal ulcers, saddle nose deformity. And if there is a pulmonary involvement, there may have pulmonary hemorrhage. Renal involvement is severe here with the proteinuria and hematuria and necrotizing glomerulonephritis. Second is the eosinophilic granulomatous polyangiitis. It is also a necrotizing vasculitis, where there is eosinophilic infiltration in the small and medium-sized vessel. For the classification of eosinophilic granulomatosis, we have following criteria. Among them, 4 should be present, like eosinophilia, asthma, sinus anomaly, mono and polyneuropathy, pulmonary infiltration, and if we do the biopsy, there will be extravascular presence of eosinophilic infiltrate. Though renal involvement is very less in case of eosinophilic granulomatosis polyangiitis. And now another is microscopic polyangiitis. It's also a non-granulomatous necrotizing vasculitis. It's a post-immune variety. And there is renal involvement is very common, and alveolar lesion is there if there is pulmonary capillaritis and patient present with alveolar hemorrhage. Other organs also involved like GI, CNS, skin, and musculoskeletal. ANCA-associated vasculitis has a very severe course, and they have relapsing and refractory nature. So for initiation of management, we have to first assess the severity of the vasculitis and organ involvement, and the remission is should be given for 3 to 6 months, and maintenance therapy should continue for 1 to 2 years. For the induction therapy, the drug of choice is cyclophosphamide, oral or pulse regime, and steroid, high-dose steroid with pulse methylprednisolone. If the patient are not responding to cyclophosphamide or steroid or not able to take cyclophosphamide due to drug toxicity, rituximab is the drug of choice. And there is also role of plasma exchange in case of rapidly progressive renal failure patient and who have alveolar hemorrhage. So there is an RCT which where the author has compared the role of pulse versus daily oral cyclophosphamide. The patient were followed up for 4.3 years, and the number of patients was 148. There they have shown the use of daily cyclophosphamide to pulse cyclophosphamide, no significant difference in the death outcome. But relapse is less in the group of daily oral corticosteroid, daily cyclophosphamide. It showed that 15 patients of daily cyclophosphamide having relapse in compared to 30 patients in pulse group. And the relapse they have defined here with the Peer 3 ANCA level. Another RCT which has compared the use of rituximab versus cyclophosphamide as a Cyclops trial. There 197 of eligible patients were taken. They are divided into two groups. One is Ritux group and other is cyclophosphamide group. The initial disease criteria is almost same in both the group. And primary outcome in case of rituximab group, they have shown that 63 patients reached to primary outcome in compared to 52 patients in case of cyclophosphamide within 6 months of treatment. It's also showed that in the Ritux group who are more refractory or relapsing in nature, their remission rate is higher than the cyclophosphamide group. And there is now the plasma exchange. There is a role in the though there is no role in the routine therapy, but there is some evidence that in case of renal failure patient and the pulmonary hemorrhage patient, who plasma exchange cause a recovery rate of 75%. In compared to non-plasma exchange group, there is a recovery rate of 40 to 50%. Though in the survival rate, there is no significant difference. So another RCT is a very large RCT done on 95 centers, and their number of patients was 704, and it was published in February 13, who have compared the primary outcome as a death due to end-stage renal disease or other disease. The death rate is equal in the both group of plasma exchange and not plasma exchange group. And they have also showed that the reduced dose glucocorticosteroid and the standard dose glucocorticosteroid doesn't make any difference in the death outcome of. So next to induction therapy, now I'm going to discuss on maintenance therapy. It is also very important, as I already told you, that ANCA vasculitis have a very relapsing course. So maintenance therapy should be continued with azathioprine, mycophenolate mofetil, methotrexate, and biannual rituximab and steroid with very low dose steroid. So another RCT on number of patients of 156, where they have compared the use of mycophenolate mofetil versus azathioprine, and the patient were followed up for 39 months. So there they have shown in the mycophenolate group 42 patients compared to azathioprine group of 30 patients have a relapse. And so there in mycophenolate group there is unadjusted hazard ratio, and but the severity of the relapse is not different in both the group. Almost severity is equal. And another RCT is compared the role of rituximab versus azathioprine. There 115 patients were included, and in two group, one is Ritux group and other is azathioprine group. So in the Ritux group, they received rituximab in 0 day, 14 day, then every 6 monthly. And azathioprine group, they received 2 milligram per kg, then followed by 1.5 to 1 milligram, and they are followed for 28 months. So they, in the graph, they have shown the patient who are on rituximab group, they are having less relapse. Only 3 patients got relapse of 57 patients, and the azathioprine group having 21 patient of relapse. But the severity of the relapse is equal in both group, rituximab and azathioprine. So from the above discussion, we came to know that the role of biological agent is very important for primary systemic vasculitis. So there is an review in the pediatric nephrology on 2018. There they have recommended some biological therapy for childhood vasculitis. So in case of GPA and MPA, the role of rituximab is there. It is indicated in relapsing and refractory disease for remission. And on EGPA, Ritux trial are still ongoing. And the patient of Kawasaki disease who are refractory to IVIG treatment, infliximab has some role. And in the patient of Takayasu arteritis, there are some case series of using anti-tumor necrosis factor blocker, but there are side effects of infection. And in case of PAN, the patient who are having monogenic variety, the anti-tumor necrosis factor can be given, but there is confer and increases of developing PAN. And in case of HSP patient, rituximab should be used in the patient of IgA vasculitis and refractory nephritis and nephrotic syndrome patient. Mostly adult study are shown the benefit, but anti-tumor necrosis factor blocker can also induce HSP. So last but not the least, we have to monitor the drug toxicity and relapse symptom in case of patient. So we have to monitor the blood count of the patient, and we should take care of the infection screening, the cardiovascular disease changes or any morbidities there. We should concern for the vaccination status of the children, and also there is some rule of using prophylaxis drug for pneumocystitis or streptococcal infection. And if there is relapse, we should, in mild relapse, in case of mild relapse, we just increase the dose of steroid. But if there is severe relapse, we have to further induction treatment should be started. So to conclude, childhood vasculitis, though it's a rare disease, but its morbidity and mortality is very high. There is inadequate studies of vasculitis among pediatric patients. Treatment still relies on the case studies of adult patients, and renal function is the key factor for long-term prognosis. Biological agents offer an important new treatment strategy in case of primary systemic vasculitis. So collaborative research is essential to outline the treatment plan and prognosis of vasculitis of the patient. Thank you all.
Okay, thank you, Dr. Jubaida, for a very comprehensive presentation. You covered almost all forms of childhood vasculitis, including the monogenic ones, and summarize the treatment very well. So, Kalaivani, Dr. Kalaivani, can we take questions now?
Yes, sir. We can take the questions, sir.
Okay, so I have the question on my chat box, and this is for Dr. Gopalakrishnan. And if Dr. Gopalakrishnan is there,
I think sir is there, sir.
So I'll read the question then. This is a question from. Yes. So this is a question from SIUT, the Sindh Institute of Urology and Transplantation, Karachi. And Dr. Irshad is asking, can we label or C3G on the basis of immunofluorescence in the absence of electron microscopy, because electron microscopy is not available because of in resource poor, resource limited setup?
Sir, Gopalakrishnan is is not there. Like he is present, but physically he's not there. I think we'll have to give him 2 minutes time. Can we take up questions for Dr. Jubaida? Is that fine, sir?
Okay. So yes. So sure. I'll start the questions from Dr. Jubaida.
Yeah.
So this is the question for you. What are the biomarkers and clinical criteria for assessing risk factors causing progression of disease in HSP vasculitis or ANCA-associated vasculitis?
Okay, so there are some biomarkers that have mentioned in different articles, though these biomarker tests are not so available and very expensive, like galactosylation of IgA1, some interleukin 6, 8, and 10 level, and some IgG3 level in the urine, IgG3 creatinine ratio in the urine, and IgM creatinine ratio. But I don't know is all are available is not. So we usually depend on the risk factors, clinical risk factors of the patient to pretend that the patient is going to have severe kidney disease or not. Like if the patient having persistent purpura, or there is symptoms like GI involvement, or their GI hemorrhage is there, and initial nephrotic range proteinuria is there, we can suspect that the child will develop severe kidney disease. So over to you, sir, if you can add something.
Okay. The second question is, how can COVID multi-inflammatory syndrome cause vasculitis and AKI in children? And so can you just briefly answer this question?
It's actually the main feature is like the infection mediated, or this what we pro-inflammatory markers, like the way the other vasculitis is dealing. So it's also like in case of COVID also the infection can cause vasculitis. And AKI, it's a many cause, like if there is the fluid cause or the infectory mediator cause, it can also cause the AKI. I think like the other,
so what you're meaning,
same as the vasculitic features, like other way the infection causing vasculitis in COVID also the same phenomena.
Okay, so there is another question for you which says, what are the clinical symptoms or lab parameters that should patient monitoring in childhood vasculitis? So this is a very broad kind of a question.
For patient monitoring, actually, it's very important because the child is on immunosuppressive drugs. So we have to monitor clinically as well as some lab parameters we have to follow in our routine follow-up. So in routine follow-up, if the patient initially having the features like purpura or hematuria, they may present with this kind of feature in relapse cases. And some tests like this active fuzz reactant test and the urinary we should do in the follow-up in case. And there is some role of von Willebrand factor also. It proves the endothelial damage. So in relapse, in follow-up, we should see on von Willebrand factor. There is some scoring system also, like a Birmingham vasculitis scoring system. And in pediatric is the pediatric vascular activity score, which is adapted from this Birmingham vascular activity score. So these are some trial ongoing in the randomized control trial to see the active process of this vasculitis.
So one can follow a PVAS or a BVAS scoring system for activity, and at the same time, it would depend on various kind of vasculitis, the type of the kind of vasculitis, that what should be followed up. Like for example, Takayasu's arteritis, you will be looking for resurgence of hypertension and inflammatory markers, and similarly, like for ANCA vasculitis,
cardiac evaluation we have.
Okay. Then
Sir, Dr. Gopalakrishnan sir has joined, so we can take us questions.
Sure. So, all right. So, Dr. Gopalakrishnan, this is the first question was whether can we just label the patient on the basis of immunofluorescence to C3 glomerulopathy, if EM is not available?
No, you can't really do that. You have to, because it can simply be IRGN as well, particularly if there is no classical MPGN pattern in the light microscopy. For instance, a DPGN or kind of a mesangial proliferative pattern in the light microscopy, and there is a dominant C3 in the immunofluorescence. You have to wait until 12 weeks at least, watching the hypocomplementemia. If there is persistent hypocomplementemia beyond 12 weeks, you are almost certain that you are dealing with C3 glomerulonephritis.
Yes. So rightly said that if you have C3 deposits predominantly and it is persistent, then you perhaps, I mean, this is a simplistic classification given by the Sethi's group, and that you can classify them as C3G. But if you want to further differentiate between dense deposit disease and C3GN, then electron microscopy would be needed. So, sir, there is another question for you.
My sincere suggestion, a practical point will be when the differentiation between the two entities is not very clear-cut, the most important step in the management is a diligent search for any focus of infection. Because it is not always just pharyngitis and cutaneous infection that leads on to infection-related glomerulonephritis. We have had in a number of patients where relatively clinically silent mastoiditis picked up on an imaging, and then the patient undergoing mastodectomy, and then subsequent complete resolution of the renal pathology we have come across. And so a diligent search for focus of infection from head to foot, particularly the dental infections. Sometimes clinically they are not very prominent and they remain silent. So focus of infection is very, very important. Whatever be the diagnosis, IRGN as well as C3GN, because even if it is C3GN, if your next step, if the patient is not resolving, not improving, or the clinical situation is deteriorating, you have to go for immunosuppressant therapy. That time again, you need to eradicate the focus of infection. So from the presentation itself, the first step is to look for a focus of infection, and don't just stop with cutaneous and respiratory infection. Go beyond that.
Okay, so there is another question this is that how common is normal C3 in patient with C3 glomerulopathy? Sometimes histology. Absolutely. So yes.
Membrane cofactor protein related abnormalities and complement factor H related protein 5 nephropathy and so on, you can have. So hypocomplementemia is there up to 90% of the patients they have, but it is not mandatory to make a diagnosis with C3 glomerulopathy.
And then there is a follow-up question to this, that do these patients behave differently? So I believe she's asking whether normal C3 patients with low C3, are they different in terms of course?
So the determinants of the prognosis or natural history of the disease is based on the severity of the glomerular injury. That's what, now the group of the Glozan group is almost, they have neared kind of bringing out a kind of an indexing, histopathological indexing, activity and chronicity index and so on. It is awaiting validation. That will serve as a kind of a guide to assess the prognosis.
Yes, so I agree with you that normal C3 is not a differentiating factor in terms of prognosis in these patients. So there is another question that's, So there is another question that is about renal transplantation in patients with dense deposit disease, that do you encourage live related donation in these patients because there is a high risk of recurrence? And do you advise genetic test, special workup for donor if so?
So there are two issues here. One is that picking up a donor from the family, you need to rule out a kind of a hidden abnormality in the same patient, in the donor, because the chance for the manifestation of disease on the higher side. On the other side, whether it is related or unrelated, any kidney transplant is going to have the same fate of recurrence of the disease. So, but that itself is not a contraindication. It is not a contraindication for transplant, because maintaining a patient on maintenance dialysis, either form of dialysis, and comparing that with the well-being of the patient after receiving transplant, any day transplant is better. The only thing is that we need to be avoiding, and we have to be looking for the recurrence, and we have to appropriately counsel the family before transplant. That's all.
So Dr. Menka, I can add that the transplantation may not be denied in these patients. So if you can have a cadaver kidney, that is fine. But otherwise, if the parents are willing, you can go ahead with live related, knowing that the risk is high. And genetic tests are not very useful in C3 glomerulopathy.
Because
sure.
Only in familial forms there is a clustering of the disease among the family members. Otherwise, most of these mutations, they don't run in the families. It doesn't follow a particular pattern, and it is not affecting all the siblings and so on. There are entities known as familial C3 glomerulopathy, and of course familial C3GN, that is due to complement factor H related protein. But not every case of Vasculitis or this thing does have a genetic, a kind of a familial cluster. That's what I'm learning.
So that would be factor CFHR5 related nephropathy, and that's correct. But in general, the proportion of patients who would be having genetic cause in atypical HUS is far more higher than C3 glomerulopathy. And also the type of genetic testing will have to be different, because if you have to look for CFHR5 associated nephropathy, you're looking for large copy number variation or large deletions, where your NGS might sometime not pick it up. So Dr. Gopalakrishnan, there is another question for you. We have a child who presented 4 years ago with suspected C3GN, low C3, IF C3 dominant, and EM could not be assessed, progressed to ESRD rapidly, and on hemodialysis for more than 3 years. Currently anuric, C3 normal, genetics not no abnormality. Would you transplant? I think the answer would be the same. I think maybe you can still yes. Yeah.
Exactly. You have to go for that.
So Rajiv, I think the answer stays the same. Even if it's C3GN, the risk of recurrence may be high, graft loss is much lower, and you would still offer them transplant. Okay. So there are no other questions now. There are no current questions.
So, shall I add just one point, concluding remark?
Sure, Dr. Gopalakrishnan, you should.
What has made me wonder on this disease entity is that it is basically kind of most of the patients have some genetic abnormality. Most of the patients, not all, most of the patients have genetic abnormality. And I have been in the field of nephrology from 1994. How come only the last 1.5 decades, every center, not just in India, but almost across the globe, they are coming across more and more of atypical HUS, more and more of C3 glomerulopathy. Does it mean that last 1.5 decades, a lot of genetic mutations? Not at all. To have a population to undergo a kind of a genetic change, it takes thousands, if not millions of years. So we have the population has been having the genetic defects and mutations of the alternate complement pathway forever. But not every person who has this abnormality in the alternate complement pathway goes in for a disease. Most of the situation, there is some environmental trigger is required. So what is that environmental trigger that has happened over the past 15 years? That has to be the topic of intense research. More and more evidence is accumulating in terms of environmental pollution, particularly the particulate matter and so on, or the chemicals in our life, or some change in our lifestyle, either food or water or soil or plant which we are consuming, animal which we are consuming, or environmental pollution. So this has to be, because the genome is the same, but why the profile of glomerular disease suddenly changed? That is the very invigorating question that has been bothering me all the time.
Okay, so I have a comment on this, further to this, that these disorders were there, always there, and the improved understanding over the last 1.5 decades has led to increased, identification of these conditions. And you are absolutely right that there may be a genetic predisposition, but there is very often a secondary hit. And we were trying to look at those secondary hits in atypical hemolytic uremic syndrome, that very often we believe that there is an infectious trigger that results in activation of the alternative complement pathway. It is not very well defined, and it's an area of future research.
And we had much more infections in the previous year rather than now.
Yeah, you're right. So there is,
number. That's what is the peculiar thing over here. Anyway. Okay.
Okay, so very thank you to both the presenters, Dr. Gopalakrishnan. It was a pleasure. It was an honor to have you, and your talk was very comprehensive and very instructive. Dr. Jubaida, you're very good and very extensively you presented the childhood vasculitis, and I'm very thankful to both of you for your presentations. And I thank you all from everybody's side. And Dr. Kalaivani Ganesan, it's been a pleasure moderating this session and these two wonderful sessions. And I'm quite glad that you gave me the opportunity, and I'm quite happy about it. So over to you for concluding remarks.
Thank you so much, sir. Like I should actually thank all the three speakers who had been wonderful faculties for the day, who had made the talk very interesting as well. It is actually more of adult talk, which has been extrapolated to pediatric population. So you did real justice for the talk. Thank you so much, sir. Pankaj sir, thank you for the wonderful moderation. Gopalakrishnan sir, thank you so much for the all energetic talk you had given. Thank you so much. Thank you, Dr. Jubaida. Thank you so much, sir. Good night, sir. Thank you so much. Bye, bye, sir.
Good night.
Thank you.
Okay.
Okay, bye.
Bye, sir.
Thank you.